Hi, everyone. It's Sam Collins, the coding and billing expert for acupuncture in the American Acupuncture Council. We're here for you, and we want to make sure your practice continues to thrive. Let's get into it. Let's talk about what's happening with documentation of acupuncture services, specifically time services. This is continuously a problem, and I want to help you solve that and make sure you understand it with some ease to make sure your claims are paid and make sure you're getting paid what you're supposed to be paid. So let's go to the slides, everyone. Let's talk about documenting and recording time specifically for acupuncture. Where we've run into a ton of trouble is to realize that acupuncturists probably never really learned this correctly and don't understand the value of their time. I think acupuncturists, probably more than any other provider, spend more time with their patients one-on-one than any other provider. And I've been to lots of different types, but my acupuncturist is the one I spend the most time with. All I'm saying to you is that's true. Let's make sure to document it. So acupuncture highlights specifically time, and I underline it here. Notice each of the codes indicate initial 15 minutes of personal one-on-one contact. The additional one, each additional 15 minutes with personal one-on-one contact. So it means that acupuncture requires that you spend time one-on-one with the patient and, of course, inserting needles. Now, I just highlighted the manual acupuncture, but the same is true for electroacupuncture. Whether or not it's electro or manual, please document the time. It's the one area that so frustrates me because I have so many good acupuncturists who are doing really well and getting paid hundreds of dollars per visit on some insurances. I kid you not. But we run into problems where their claims are denied. And I want you to see what's occurring. Here's one for United Healthcare, and you'll see here, this is for 97811 and 13, and it says not supported. It says the add-on type of code requires a primary code and cannot be accurately seen. Therefore, the validity of the accuracy of the billed service cannot be verified. So in other words, there's no time. You think, no, it doesn't say that. Let's see. 97813, the initial one says, the submitted medical records do not support 97813 was performed. The documentation submitted does not indicate the time was personal one-on-one contact. Now notice it's telling you the time didn't indicate as personal one-on-one. It is not sufficient to just say time, because time could be the time the patient is resting on needles. We want to know the one-on-one time. Now, here's an interesting one. Notice some of the claims, and initially for the follow-up set says not supported, but notice the initial set is. So what did they do differently on the first they didn't do on the second? You've got to get in the habit of saying, I spent one-on-one time. So by example, what is this one-on-one time? And I think many acupuncturists forget what this really includes. So let's get into this 15-minute code. The 15-minute code is personal one-on-one contact. Literally, that means on an acupuncture visit day, not with exam, just treatment, as soon as you walk in the room with a patient, the time starts. So what I'd like you to do is look at your watch and go, oh, started at 10:05 or whatever the case may be. Give me specifically the start time, or at least start a timer, because this means, and you'll see here, the acupuncturist is in the room with the patient and actively performing a medically necessary component of acupuncture. Now realize, what is that going to include? When you first walk in the room, you might review their note and say, hey, last time you said such and such. That's included. It's going to be review of the history, asking them how they're feeling. Notice none of this is even yet putting needles anywhere, but just asking the patient what's going on. It's then going to include your day-to-day evaluation. Could be tongue and pulse, range of motion, you name it, any of those things you might do. Realize includes washing your hands, sanitizing, choosing the points, cleaning the points, getting the needles open, inserting the needles, manipulating the needles if you have to. And of course, it actually includes removal. So you know how you're in the room with a patient, you might leave them rest on needles? Maybe you come back 10 minutes later. As soon as you walk in the room, time starts again, because the time to take the needles out and dispose actually counts. And notice this component, as well as completion of chart notes while the patient is present. So that means you finish it up when the patient's there, that actually counts. Now, what wouldn't count is if you do it later sitting in your office, but if it's while the patient is there, it all counts. So you know, you're asking those few questions at the end, just give me the total time. I'd love that we'd have a program somehow, maybe there's a mat. When you walk in the room, the mat turns on a timer. And when you walk out of the room, the night timer goes off, because if you're in the room, it's a component of acupuncture. You're doing something towards it, unless it's another therapy. Now, where a lot of people get fooled on this, though, because they say, well, Sam, it's 15 minutes. Do I actually have to spend 15 minutes? Technically, no. It's what we call the 8-minute rule. And this 8-minute rule is true for all codes that are 15 minutes when it comes to CPT, including physical therapy and physical medicine, but actually acupuncture. So I've given you a simple breakdown of it. Notice 1 unit is at least 8 minutes. So do you have to spend 15 minutes to do acupuncture? No. If I spend 8 minutes and insert a needle and I can remove it and they're out of there, that actually could be enough time. Now, I don't think anyone's doing an 8-minute visit, but I think you get the premise here is that we're just looking in increments, that if you're doing more than 50% of the time, meaning 8 minutes, you qualify. I don't think anyone has any problem doing the first 8 minutes, of course. Where things get a little trickier, though, is how do we do an additional set? That requires additional time and additional insertions, but it doesn't require at 15 minutes. The answer is no. It requires an additional 8. Now, here's where it's confusing, though. What if I do 8 minutes on the first and go, I did 8 minutes on the second? What's the total time for 8 plus 8? 16. Is that enough? No, because there has to be at least 23. So realize the second unit of time, that 8 minutes, begins after 15 minutes and it's plus 8. So that's why you'll see 1 unit is as little as 8, but 2 units or 2 sets is 23. 3 sets would be 38. So you have to make sure that time matches. So by example, if you did 8 minutes on one and 8 minutes on the other, that wouldn't be enough. It would have to be 15 plus 8. Or how about this? What if you spent 12 minutes on the first one and 11 minutes on the second one? Would that be adequate? It would, because there's 23 minutes. So please make sure that you're just simply documenting the time. Notice it wasn't saying the time wasn't documented. They were indicating the time wasn't clearly indicated as face-to-face. So get in the habit of saying face-to-face time with the patient. Because what if there's time where the patient's resting on needles? I know when I go to my acupuncturist, she will put in needles, then she usually leaves the room about 10 minutes or so. Great. It gives me time to relax. Realize, though, that time simply doesn't count towards the coding, but then when she comes back, it does. So it has to be actively part of it. So if you come back in the room and stimulate needles, it would be. If you come back in and insert more, that would be an additional set. So please note here, it says, yes, do you have to do insertion of needles to count? Yeah, reinsertion, bad term, of course, but additional insertion. So keep in mind, just retaining needles for an extended period of time does not give 2 sets. Stimulating needles does not. There must be an insertion. So keep that in mind and realize I'm showing this is from Regis Blue Cross Blue Shield from their acupuncture part. Notice it says here 8-minute rule, 8 to 22, 23 to 37. So you can see clearly this is not just a SAM rule. I'm not trying to just say I'm the know-it-all. No, I'm giving you the rule based on the guidelines. Notice it says if you do 7 minutes or less, it doesn't count. But as soon as you do 8 minutes, yep. So right in there, you can do it. So realize that United Healthcare is the one I just showed you that it had a problem. And it says, for any time-based code, the duration of service must be clearly documented. And the time service is not clearly or properly documented, then the service is not supported. And it needs to be because we have to indicate face-to-face time. Acupuncture, often patients will rest on needles. And so the reason that we're seeing some of this is because I think we're combining that and not separating it out, or just not making it clear. Just make it clear. Notice a couple of things here because it tells you how you document. So you might wonder, how do I supposed to document this, Sam? It's unacceptable documentation of time-based services. What's unacceptable? Documenting in terms of units. You can't just say I did 2 sets of acupuncture. You can say that, but I need you to tell me set number 1, how many minutes did you spend face-to-face and where'd you put needles? We cannot use a range of time. You can't say I spent between 20 and 25. It should be I spent 20 or 21 or 22. You also want to make sure that you're not specifying a measurement or increment used, meaning that I did from this time to this time, that range part, or just not mentioning time at all. I think the easiest way to see this, though, and for those of you that have been to a seminar with me and or have our AcuCode, you've seen this is a sample of a SOAP note. What I want to do is just blow up where the area is that time is documented. Take a look here where it talks about acupuncture, and it says set 1, 2, and 3. Now realize this form, if you wanted to add a 4th set, you just add another column. But nonetheless, notice set 1. The points that were inserted or reinserted, could be either one, we list the points. And then we indicate face-to-face time, 5:20 to 5:45. That's 25 minutes. Notice there's retention time. There is a rest period. But notice set number 1 is 25. Notice set number 2, 5:55 to 6:05. That's only 10 minutes. But does that meet the 8-minute rule? Yeah, it's more than 8. plus the first one being 25, that's 33. We're easily above. And then notice the third set is 610 to 630. Now, I may wonder, how come the middle set was so much shorter? It doesn't take that much time to add more, probably. And the last set was also 20 minutes. Why was that last set longer? Think of all the things you do at the end of the visit: counseling the patient, removing the needles, and disposing. Just give me the time. None of that is hard. Acupuncturists, by right, always brag about how much time they spend with someone. I talked to someone this morning that goes, Sam, I spend, God, between 40 and 50 minutes with every patient. And I believe that to be pretty true for most of you. You know what I want from you? Document it. You'll never have an issue. Now, you may think, I only do cash. Great. You still have to document the services. So realize this has nothing to do with insurance. This is just to do with you properly documenting what services were provided. Tell me how much time you spent, what points you did. We're good. It will also equal you get paid. I'm not sure you noticed, and I'm not going to go back to it. Did you see the prices on some of that United Healthcare? So if you want to rewatch this later, you're going to go, oh my gosh. Now, I'm not saying we want to bill that much, but if you're in certain areas, why wouldn't you bill what it's actually worth? Acupuncture is a great service. You're at a great time to be an acupuncturist. Take advantage of the advancements of your field in getting access, but please document the time. It'll never be an issue. I want to say thanks, but realize we're here to help. Our network service and our seminars are where you can go for one-on-one help. We can do Zooms together and deal with you specifically, not just a general question. Please go out and do well, because we're dependent on you. The American Acupuncture Council and myself, we count on you. Your success is ours. Until next time, my friends. Greetings, my friends. This is Sam Collins, the coding and billing expert for acupuncture and for you, but the profession as a whole. Thank you, American Acupuncture Council, for the opportunity. But let's get into it. What's going on, particularly for the first of the year? You're always thinking business, money, pricing. And many of you have joined these HMO/PPO plans and may have been in them for years and are noticing, I'm getting paid the same thing year after year after year. And at some point, that becomes unsustainable. So, is there a way to request or to get an increase in a PPO rate? Because if you think of it, they never do it. But is there opportunity to do so? Yeah, I will certainly say I've had offices that have had success in getting rate increases for PPOs. But there's a way to do it that I think will lend to potentially having more success. This is no guarantee, but potentially more success in getting a rate increase. So let's go to the slides. Let's talk about that. What things do we need to do to help ourselves request a rate increase and really get one? It comes down to making sure you create really a value opportunity about your office. I want you to write a letter to them and request specifically an increase, but by writing a unique value proposition that makes your practice stand out. Maybe where you're located. Okay. It might be an underserved area. Those types of things are helpful. But more than anything, always go by what's your status within the plan. Show your value. I'm sure many of you have heard of the company ASH or one similar, and you can rise in status from tier 1 to tier 6. Obviously, the higher tier status you have, the more prestige you have in the plan, and that creates more of a value. They want to keep those higher performing providers. And if you are one of those, that certainly makes it much, much better. You want to also focus in on your utilization. Bear in mind, we do understand these plans raise your tier by not overutilizing care. That doesn't mean you shouldn't do the care that's necessary, but be mindful. They're not expecting everyone should get 20, 30 visits. They're expecting actually an average about 8 visits per patient or per condition. And what that means is you're going to have some patients that you might see 20 times. They need it. There should be a balance with maybe seeing some of them 2 times so that that average comes in. Realize, don't let one patient plan set it up, but the average over time. And if your numbers are lower, or you can show that, you would point out, heck, my average is 6, let's just say. You want to also highlight, what about the number of providers that might be in the region? Some areas are very underserved, particularly now with the viability of acupuncture, the VA, and all these things. They're looking for providers. And if it's an underserved area, that's going to help. But even if it's overserved, if you will, there's a lot of providers. Where do you stand out? Your availability, your location, your hours, your languages you speak. I mean, what if you have multiple languages? I would highly recommend, if you have multiple languages spoken in the office, it should be brought up. Do you speak Spanish? Do you speak Tagalog? I mean, think of any type of language. It's going to be helpful to create access, because that's very important to these PPO plans, always creating access. Make sure you also kind of point out their value compared to other existing contracts, other plans you're part of. But I would start with Medicare and workers' comp. I mean, my goodness, even Medicare for 2 sets, when you look at the Medicare rate, allows $70. Workers' compensation is usually a percentage of that, usually anywhere from 120 to as much as 200% of Medicare. So therefore, you want to start to use that to say, how is it a PPO thinks they're sustaining when they don't even meet the value of Medicare? And Medicare is the low end. I mean, ASH is going to pay many acupuncturists 42 a visit, which is literally 1 set, even for Medicare. And if there's 2 sets for Medicare, you get 70. So it's probably unsustainable, and it's not reasonable, really, because you have to look at inflation and cost of practice. Don't be afraid to bring up about your own specific issues in your practice. What has cost more? Certainly, when you first started practicing, your rates have increased. I'm looking at rates of rent now, which are through the roof. I mean, how could that be sustained? Look at gas. The cost of phone and internet, all those things are part of a practice and cost. So you have to make sure that you're creating all of that with the window to show your value and unique value to that plan of how you've helped people. Don't be afraid to get a few testimonials from patients of how you've helped them. Make sure they're ones too that the patients didn't have something where they needed hundreds of visits too. But nonetheless, those types of things are going to be helpful, because an insurance company has a vested interest in making their clients happy. You want to show that that's what your job is and what you have done. So here's kind of a way to kind of focus that. This would be kind of the highlights of how to put together some type of proposition or letter to the carrier. And you can point out, I've been a panel provider since, say, 2015. For some of you, it might even be longer. I support the development of managed care in the acupuncture because it helps to standardize documentation, promote evidence-based care, and create greater accessibility. We want people to have access to get acupuncture. We do. But we've got to make sure in doing so, we have to have a reasonable amount that's paid to us to sustain it. You'll highlight to them there's been no significant change in reimbursement from your plan, and I've been a member for decades maybe. These days, I've increased costs, staff salaries, rent. Think of the work we have to do now with electronic health records, electronic billing, all the costs that are there. I mean, a lot of these plans require you bill electronically. That doesn't happen for free. Therefore, that's got to be brought in, software contracts and so forth, not to mention your rent and the other things that go with maintaining your practice. And frankly, the cost of other things, cost of gowns, cost of needles, it's all increased. You'll highlight to them, my overhead is nearly 4 times of what it was when I enrolled with you. My average cost of seeing the patient now is 41 a visit before there's even a profit. So some of these plans are paying as little as 40. So you got to think, wait a minute. If my cost is 41 and I'm getting 40, does this make any sense? No. Can you imagine every business just exactly makes what their actual costs are? You can't stay open. There's just no way. So this level of reimbursement is not a sustainable model. And while being on the plan may create a greater volume of patients, there's still a limitation. Let's face it, an acupuncture visit is typically 30 to 45 minutes. How in the world can you sustain a practice where you're getting paid less than $80 for an entire hour of work, maybe an hour and a half, and then going to be able to maintain that practice to be open. Think of just what you're paying per square foot. I mean, in some ways, I would argue we might be better off working at Starbucks or Panda Express, considering some of those places pay 40 to 80,000 a year for a full-time worker. I mean, come on, as a healthcare professional, they can't have rates that are at least sustained at that level. So you want to start to point out that hypocrisy by pointing out the rates for your insurance have increased to allow the plan to remain solvent. I get that. Has insurance companies increased the rates to their insureds every year? I know when I redo my insurance every September, there's been an increase every year I've been in there. However, are providers part of this increase? Isn't it interesting how insurance companies typically say, well, we've had to increase the rates because of the increase in cost? And I agree, there's an increase in cost. Where isn't there an increase in cost? What provider is still getting paid the same amount they have for years? So in reality, the provider costs are flat. Yet they get all these raises to do what? Now, maybe that's to cover drug costs and all that. But at the end of the day, how could they say we're part of an increased rate when they've not paid us any more money? They're thinking you just can see more people. Well, how could we see more people if it takes that much time? So it's unreasonable for providers to bear this cost with no consideration while the plan has increased their premiums and the adjustments in pay to their workers. If you work for these plans, I bet many of them, if not everyone, gets some type of adjustment yearly, 2 to 3%. I'm looking at least for that. I would think if you haven't had one in a while, what about a 10 or 20% jump for this year? Because to sustain it in this way, at some point, just cannot be sustained. In my observation, healthcare services are the cornerstone of this business and have been left out. I'm requesting, if you're getting per diem or even if it's per service, a certain request over that, which will allow me to continue to welcome these patients to my office in the future. Because without an increase, I will no longer be able to sustain the relationship. Let's be reasonable. It just won't. In fact, I've had a lot of offices that realized that it was a sum negative and they've dropped out. And this is someone I spoke to last week. This is not an exaggeration. They pointed out that they dropped out of one of these plans and they first were very panicked because they thought, oh my God. And they go, oh my God, Sam, in the first 2 months, they lost 30% of the patients. But here's what they realized. They lost 30% of the patients, but that only equals 6% of the revenue. What does that tell you about this plan, how bad it is? All this work and emphasis, maybe it's not worth it. And this is something that you have to start to look at as a business decision. There's nothing wrong with being part of these plans if they're at a sustainable rate. But if they're not, maybe it is time to move on. And this is what we look at. If they can't sustain it, then let's move elsewhere. Don't be afraid to make a move. Don't be afraid to request. Because at the end of the day, the power is with the providers if we wield it. And don't be afraid that that ultimate power is your patient. And if that patient is still coming in without the plan and paying a fair rate, why would I push for this thing where I'm getting paid $25, $30? So do be careful. But I'm not saying not to request, not to do it. But at least this way you'll know where you stand. And if they're treating you that poorly, maybe it's time to move on. Don't be afraid to break a relationship that relationship does not have mutual parts that are beneficial to both sides. And that rate increase to us, I think, is important. And without it, maybe we can't stay there. So don't be afraid. I wish you well. As always, the American Acupuncture and myself are always there to help. Our service, the network, is a place where you can go and work with me one-on-one to really write up a protocol like this. I really wish you all well. Continue a good practice and enjoy what you do. Hi, everyone. This is Sam Collins, your coding and billing expert for acupuncture, the American Acupuncture Council, and of course, you. Let's make sure your claims are getting paid. And I don't care whether you're doing cash, insurance, or otherwise. We always want to make sure you're doing well. We have a vested interest in you. Well, today I'm going to spend some time talking about evaluation and management services, or E&M codes, or exam codes. And I've recently had a lot of offices with issues of, Sam, my exams are being denied or they're not paid and they're giving me excuses that don't appear right. So let's talk about that a little bit. Does a patient require an exam? Of course they do. Well, let's get into that. Let's go to the slides. Let's talk about what's going on and getting paid for your E&M services. How do I get paid for my exams? And I use the term exams because often people will say E&M and then they say office visit. And I want you to keep in mind an office visit is anything that you do when a patient comes in, they're visiting your office. So keep in mind, office visit from your standpoint should just be the visit overall. It depends on what you do. So by example, on days you do an exam, that would be an E&M service, and you may do treatment the same as well. So be careful. The term office visit will often get you confused. What I'm speaking about for exams, of course, are evaluation management, or E&M codes, if you've all learned. And you'll notice we have two types, the new patient, the established patient, 202s to 205 for new, 211 to 215 for established. And what are these for? For the indication when the patient required an examination by you to determine their diagnosis, their need for care, and so forth. And so we're broken down into 4 codes for new patients, 5 for established, and they're pretty straightforward. They just indicate how much time or how much medical decision making did you spend doing an exam. You should be familiar with that. That's not the hard part. Where we run into problems often is I'll get offices saying, Sam, I billed for an exam code and I didn't get paid. The insurance said it's not a covered benefit or it's included in something else. So what is it that's required to do or get paid for an exam? Well, let's think of it. An exam is something that's absolutely required. If an insurance says that you shouldn't do an exam or it's not within scope, I can't believe that not to be true. I mean, obviously, when a patient comes in, what's the first thing you have to do in order to know whether you can help them? You have to evaluate them. It's required to determine the condition and their need for care. What's wrong with them? And then, of course, I would argue it is a ethical and legal requirement. Can you imagine the liability if you said, hey, I don't care what's wrong with you, just shut up and lie on the table and start needling in you and go, well, we'll see what's happening. I don't care what's wrong. Well, of course not. It is an absolute requirement that you make some level of evaluation to determine the need and necessity for care. So I'm going to say it is an absolute requirement to do an exam. However, where the confusion comes in is how do you bill for it and how do you document it? Well, let's realize the one thing that's probably the most common issue for acupuncturists being denied for exams is the failure to understand that every time you bill an exam code, an E&M code with treatment, you have to put a special modifier on it in order to determine and to demonstrate it is separate from the exam associated with treatment. So notice here it talks about the acupuncture services or procedures includes an E&M assessment. So in simplest ways, think of it this way. If you saw someone for the very first time, you are clearly going to ask them lots of information about who they are, what's their symptoms, what's going on, what makes it worse, what makes it better. In other words, you're going to do a pretty detailed history. You're likely going to do some physical exam things. Maybe it's tongue and pulse, maybe palpation, range of motion, you name it, the many things that acupuncturists might provide. And then based on that, you're going to determine a diagnosis and then begin some treatment. Well, those things actually are somewhat included in the acupuncture service, but here's where we have to be unique. Realize the acupuncture service does include a small exam. Now, the first visit, the one I just described, is clearly different, above and beyond. But let's talk about that first visit is one thing, but what about when the patient comes the second time? Maybe I come to you 2 days later and you say, hey, Sam, how are you feeling? Is that a little better or worse than last time? How much time did the pain resolve for you? In other words, you're going to do a little short exam that includes a little history, maybe some findings such as, tongue and pulse again, and then begin treatment. So there's what we call a pre, intra, and post-service evaluation associated with treatment. So here is the number one reason most acupuncturists are denied for exams. You forgot to tell them this exam is above and beyond What I normally do as part of the visit, it's a true examination, and we have to put modifier 25. So if you've been denied for an exam and you're not familiar with 25, that's probably the number one reason. That modifier is necessary to indicate to the carrier that this examination was separate and distinct and therefore payable. No modifier, no money. Now, why is that? Because you'll see here, there is a pre-service associated with treatment. When they come in the second time, you're going to do a little review of their record, a little record review face-to-face time with them, do some evaluation things, get them set up for care, perform the care, and even after the care, you're going to evaluate, hey, how are they doing? Give them some recommendations for at home. And this is why it says specifically in the CPT manual, it says what you see at the bottom here. It says additional evaluation and management services may be reported separately if and only if the patient's condition requires a significantly separate identifiable E&M service above and beyond the usual pre and post service work associated with care. So in other words, we're saying, no, this is not the one that we do day to day, but this is the one above and beyond. So to come full circle with that, when is that necessary? Well, clearly the first visit. There's no doubt a first visit should be separately paid for an exam, and we put a 25 because that's clearly above and beyond what you would do on a follow-up. Now, when would it become necessary again? Now, some of you say, well, Sam, I do an exam every day. That's exactly what we're pointing out here. You do, and we understand that, and a little bit of that is associated with the treatment. Keep in mind, that's not only true for you as an acupuncturist, that's true for medical doctors, chiropractors, physical therapists, anyone that's doing this type of care would have the same provision. So they have to put the modifiers as well to show that it's separate. So we have to make sure it's above and beyond. So it says here, if and only if it requires a significant one. So the day-to-day one you do for several visits after, not really. But when would it be appropriate? Certainly every 30 days. Now, why every 30 days? It's the standard. It's the one set up through Medicare that all insurances have adopted. So an exam on the very first visit and one every 30 days, absolutely reasonable, should be payable. Just remember, assuming there's treatment, put a 25. Well, what if you say, what if I don't put a 25? You won't get paid. Now, you don't need a 25 on the day-to-day one, but on the one that's exam. So the first visit, and then about every 30 days. Now, some of you say, well, I like to do it every 6 visits. No, it's every 30 days, whether you do 12 visits in 30 days or 6. Keep in mind, it's about 30 days. Now, there could be instances, what if the patient says, hey, last night I fell down and I hurt my back? Would that be appropriate to do a separate exam from what you were seeing them before? Let's say it were headaches. Well, of course, because there's something new or significant that's above and beyond. So make sure it has to stand out. In other words, make sure the exam clearly shows that this is not the routine exam. And that's probably the number one reason things get denied. So simply put, when you're billing, put a 25. Notice this example here. You'll see 99203, that mid-level exam, but because there's acupuncture performed the same day, we put the 25 modifier on it. The 25 modifier does not change the price. It's still going to be paid the same. It just indicates that it's payable. There's no reduction in doing that. In fact, in many ways, I wonder, maybe should that have been the second thing you've learned in acupuncture school? I mean, the first thing, of course, how wonderful the profession is, all the things you can do. But can you imagine how many of you finish school and never learn this one simple thing? And then, of course, you get out and you're frustrated, like, how come I don't get paid for exams? Well, because you didn't put the proper modifier. Now, let's keep in mind, I've had some offices, though, that are saying, well, Sam, I know that, I've been doing that, and these insurances still won't pay. So what I've done here is I've taken a page from the CPT book. I just took a picture of it, put it up here. And here's what it says. Notice it says, evaluation and management services may be reported in addition to acupuncture procedures when performed by a physician or other healthcare professionals who may report them, which means you. Now, we move down a little bit here, and we'll get into this section here, and it says, it may be reported separately using modifier 25, so long as it's above and beyond. So I want to make sure if you ever get a carrier that's saying, you shouldn't be able to, I want to point out the CPT manual clearly says it. This is not unique to you. It says it the same for chiros, the same for medical doctors, and so forth. So it is absolutely appropriate. However, there are some plans that come back and say, no, we're still not going to pay. So let's talk about how to deal with if it's denied. Was it billed properly would be the number one thing. Did I put modifier 25? That's probably the simple one. But sometimes you're going to say to me, Sam, I did put the modifier 25, and it still came back and it stated the exam was included in another service. What you're going to do is push back and say, excuse me, this was done on the first visit or every 30 days, and there was clearly a separate and distinct service, an exam, that was above the routine day-to-day visit. So you're going to push back on that and basically point out to them it was separate. That's why we put the 25. But here's the bigger problem. Sometimes it's because you have a contract. It's why I will warn you. In fact, how many of you have worked with me directly one-on-one to know whether or not it's worth it to join some plans? I'm not going to say never ever, but you want to make some better choices, because sometimes when you join these plans, you join them and think, great, I'm going to get more patients. Do you know many of your contracts say we don't cover exams? So the reason it may not be covered, it's part of your PPO reduction. It's basically saying, we're going to send you a lot more patients, but we're not going to pay for the exam. And you have to make it a business decision. Is that worth it to me to get less money, but maybe more patients? In some instances, maybe. But for me, mostly, probably not. So what if the issue is part of your contract? Is there a way to dispute that? No. That's the contract you signed up for. Now, maybe you might decide not to be part of it. This is why I think of it. If you're just a cash office, isn't your first visit more expensive than the second visit? Think of that for a moment. Why is that? Because the first visit has an exam. But here's the issue we've been running into, and I know a lot of you on the East Coast. I've done seminars there up and down the East Coast, from New York down to Florida, that the plan says an acupuncture provider is not paid or may not even do an exam. We're running into this into New York quite a bit. And my answer to that is, excuse me? You're saying an acupuncturist cannot perform an exam? Would that not be against the rules of just engagement of a patient? Can you imagine the liability if a doctor said, oh, I didn't examine them, I don't care what's wrong with them, I just treated them? Well, how could you treat someone without evaluating what is wrong and knowing what to do? So there's a lot of pushback on that. If that's what you're running into, please get part of your state association, join us in fighting to say, excuse me, of course it is part of your scope. In fact, what I'll tell you is, look at your scope of practice. Does your scope of practice indicate an evaluation? I'm going to guarantee it does, at least at some level, so therefore should be payable. So be careful. I think what's happening is some payers are finding, hey, acupuncturists will just go away if we tell them no. We'll just pay for treatment. We don't want to pay for an exam. My goodness, no. If you're doing an exam, it's necessary. Of course that's payable. Why? It takes time. It takes effort to do it. So make sure that you're always pushing back. However, please be sure, if you are billing for an exam, and I don't care whether it's cash or insurance, by the way, is there clearly more information and more details that would show this visit had a distinctive exam? Keep in mind, if you're billing for an exam, there needs to be an exam above and beyond, just kind of like acupuncture. And we'll talk more about this coming up in the first of the year, but how are you documenting it? How to make sure you're avoiding anyone coming back saying the services weren't properly described. Not hard, but there's things you have to do. Have you ever had help with that? Have you ever understood it? Maybe not. That's what we do at the network. It's not just about practice and making more money, but making sure we're compliant. All those factors. I want to help you with that. That's what we do at the network. We do the education. Come to a seminar first of the year. You know what's happening? There's updates to these E&M codes. Nothing major, but enough that you want to be aware of to know which code to properly choose. And there's some additional codes that are updating as well. We always want you to be in the know. The American Acupuncture Council is your partner. I'm your partner. Your success is ours, and I wish you well. We're always going to be there as a resource. Take a look at our website. There's our phone number. Come to our seminars. We're here to help everyone. Go out and do well, and I wish you a really good new year and prosperous new year. Thank you. Greetings, all my colleagues, all my friends. Welcome to 2024. This is our first show for you. This is through the American Acupuncture Council, but I'm from the network. I'm the coding and billing expert, Sam Collins. And one of the big questions I get every year is, Sam, what do I do about fees? What has changed? What is updated? Of course, we do a big seminar on all that, but I want to give you a little thumbnail of what's going on for 2024. What can we expect for fees? Were there updates? What's going on with deductibles? Can I raise my rates? Let's get into all that. Let's go to the slides. Let's talk about 2024 fee updates. Now, when I say updates, does that always mean an increase? I mean, let's face it, for many of you who have been in practice for many years, you've probably noticed, Sam, my fees from insurance companies that I've been contracted with for years have not gone up, particularly those that belong to groups like, I don't know, ASH and similar. You'll find those fees have remained stagnant. We'll talk about how you may be able to change that a little bit, but let's talk about what's going on for 2024. I think in order to understand what our fees should be, we got to think of how are our services valued? Who determines the worth or value? Who sets these fees? Well, the fees are set really by the community in a way, though obviously it's going to come back to the payer of the service. What is the fee allowance for it? How much do we allow? What can we charge? It is interesting in our healthcare system, I'm sure you've noticed, insurance companies can tell doctors what they're going to pay, period, end of story, take it or leave it. But do you ever notice that's not the same for pharmaceuticals? Now, that's a whole nother topic we'll get into. But bottom line is there is some mandates to what fees we can charge, particularly if you're a network. So who sets the fees are going to be the community standards, of course, for cash patients, what our patients will pay. But for insurance, who sets them? How are they set? Part of it is going to be something called a relative value unit. And that is the value of a particular service compared to another. The federal government has done this since the early 80s, and they do a study each year that updates the value of services from one to the other. By example, some fee schedules just use a simple conversion, a number, and then they take the relative value of your service, multiply that, and that tells you the fee. You'll see this very commonly in workers' comp in many states. By example, in Texas, they're going to take the relative value multiplied by 6483. Or in Connecticut by 51.50, and let's say Utah, I believe by $61. In Minnesota, or excuse me, in Michigan, they allow 200% of Medicare. So it's based on this relative value, the value of one service to another. I want to give you a thumbnail of that so you start to understand what does a service value at. I find most offices I consult often have fees all over the place. One fee, great, but then the other fee in relative terms is not correct. So I want to take you through how do I make sure to have relative values work for me to know the value of a service. We'll keep it simple, but it's not that hard. Obviously, though, we also have to deal with contracts. When you belong to an insurance, they set the fee for you. They tell you, hey, join us. This is how much we're going to pay you. However, it's not going to be as much as you like, but we're going to send you more patients. So you have to determine whether or not does that offset make up the difference? Can the volume make it up, or is it fair? You'll see these with preferred provider organizations like your Blue Crosses and Blue Shields, but you'll also see this with HMOs, particularly bigger insurance companies like a Kaiser and that type, Health Net, that set a specific fee for that one. But this means also the patient can't go elsewhere. So the attractiveness is when you belong to these contracts, the patients get a better benefit, meaning less out of pocket, sometimes no out of pocket with these, but they set the fee. So you have to look at, ooh, what is that fee? Is it fair? By the way, are there some things you can do or should do yearly to see whether or not you can get a fee increase? Because if you don't ask, they're not going to do it. Of course, you have to deal with fees, but also deductibles. What happens with deductibles? Well, deductibles start first of the year, but keep in mind, some deductibles, based on when the patient visited the prior year, may roll over. So check the plan. Some plans may have, say, $1,000 deductible, but any services the patient may have received from the last quarter of the year prior may apply to this year's deductible. I always thought that was kind of unfair when you think about it. What if you got sick in December, hadn't gone to the doctor before, you pay your deductible. Then January rolls around, oh, new year, new deductible. Where now they've kind of a product where insurances that often will roll that over. So that's certainly something to look at. By example, deductibles for many types of plans can remain stagnant, $250, $500, thousands of dollars. By example, the Medicare deductible did go up $14 this year. Prior in 2023, it was $226. This year, it's $240. So do check that because, of course, Deductible is the amount the patient has to pay out of pocket. And then we have to figure out what's that fee that we're charging so that the patient is paying their portion. Because, of course, you have to remember there's going to be co-payments and co-insurance. And let's define that a little bit better, I hope, for you. When it comes to fees, the patient is to pay their portion. When you belong to an insurance like a PPO or an HMO, we often term that as a co-payment. It's a specific set amount of money that is per the contract that says, oh, this patient pays $10 copay, $20 copay. So in other words, no matter what the patient receives, you're going to get some type of payment from the carrier, and the patient's going to pay $10 or $20, a fixed amount. Sometimes it could be a percentage, though. It could be 80% of the allowed rate, which means 20% of what was billed or allowed. But often, keep in mind, we use the term copayment to mean you're in network. It's a set amount. But co-insurance would be a little different. And this is where it gets tricky. When you're not in the network, what does the patient owe? That would be the co-insurance. In other words, everything the insurance has not paid. So by example, if you bill $100 to the insurance and it pays $50, what would be the co-insurance? $50. So that means that patient would pay $50. Now, here's where you have to be careful. What if you're billing 3 different insurances and they all are being billed $100, same service? One insurance pays $50, one pays $75, and one pays $90. If you're out of network with each of those patients correspondingly have to pay you. One of them has to pay $50, one is paying $25, and one is paying $10. In other words, you're not accepting what insurance pays as payment in full, but it's a part of it to pay your full amount. In other words, you're getting paid $100, some from the insurance, some from the patient. And this is the variation that when someone chooses to go out of network, they've got to pay that entire difference. I've had a lot of acupuncture offices have some issues with that, because what you cannot do is bill insurance as a fee and then just simply write it off unless you're contracted. Now, when you're contracted, that's where the copay comes in. It's fixed. But if you're not contracted, it's the co-insurance. So do be careful when it comes to setting your fees. Should you set your fee off the best paying insurance you have? I mean, let's face it, there are some insurance plans that pay acupuncturists, and you're going to think I'm kidding for some states, $300 to $400 a visit. I kid you not, for acupuncture. That's how much it's valued. That's great. But what about a plan that doesn't value it that high? When I bill that high amount, does the patient have to pay the difference? The answer is yes. So you want to be somewhere in the middle of what you're going to afford or what a patient can afford. And remember, you always have to keep in mind my prices for insurance, if you will, have to pretty much match my cash. Now, that can vary a little bit if you're in the state of California. For me, California has laws that allow you to have kind of that dual fee, but in other states, no. The cash price has to be essentially equal to the insurance price, maybe a small time of service discount, 5 to 15%. So when we're thinking of how services are valued, how do I value them? What's their worth? How do I value it? What's the best way for me to think about it? I think for 2024, what I hope to get more offices to do is begin to realize that if you're not doing something to update your fees, carriers will not. By example, this year, Medicare has reduced fees, not by a lot, but by a very small percentage. They're thinking, oh, how dare they? Has nothing to do with the doctors. Let's face it. Is Congress and our government a little bit dysfunctional when it comes to budgeting? So, of course, where do they start to cut? Well, they cut other standard types or fees for Medicare, hence where that came from. It has nothing to do with the value. It's just, hey, we're going to cut this. So realize, be careful if you're going to use Medicare rates. Realize Medicare rates went down this year. So should that mean, oh, I got to lower my rates also? No, absolutely not. I would, in fact, think, hopefully you're doing this already. Should you raise your rates 2%, maybe 4% a year? Absolutely. Because if you do not, how do you make up the difference of cost of living? Think of it. You can go years with the same rate and go, I'm not making any more money. How would you when you're not charging more? Because if you see the same patient volume, it's going to be the same. And there's going to reach a finite point. How many people can you see in a day? That's not going to change. If you're treating a person for 45 minutes, you're going to see maybe 10 or 12 maximum. Maybe a little bit more, but give or take. So you reach a point, you have to figure out, how does this office continue to sustain when all your other increases, your cost of living prices, your cost of needles, your cost of gowns, all those things that go with your office. So we got to start to think of, I've got to start to value and make sure, am I setting the right fee? And this is where I hope to help you. Relative value units are the value or a fee comparison of medical services. And overall, every CPT code, every single one, has a relative value. And what this is based upon is the value of the service based on several factors: the work value, the cost of delivering the service value, the cost of your education. So you'll see when it comes even to acupuncture, there are variations that are year to year, and it simply just compares one code to another. So make this very simple. If you have a code that has a relative value, let's say of 0.75, and you see another code, even if you don't know what the code is, and that code is worth a 1.0, what that should tell you is the value of the code worth 1 should be 25% higher than the other, or 25% lower based on which way you're moving. Because what I often find is acupuncturists in particular, not understanding this, way undervalue services such as exams and therapies, because not understanding the real cost of them. It's kind of like owning a house in a neighborhood and not understanding the value of the neighborhood. Remember, when you do or sell a house, you don't just go, I paid XYZ for it 20 years ago, I'm going to charge this much more. What are you going to do? You're going to look at the cost of the neighborhood. That's what relative values do for you. So let's look at what's happened from 23 to 24. And you'll notice not much of a difference. 1.14 is the value of 97810 in 23. It moved up 1 percentage point in 24. 97811 was 0.86, now to 0.85. But what I hope you're seeing here, do you notice that's a 30% difference? The big takeaway here is, whatever my price is for my first set of acupuncture, the price corresponding below it should be about a third or 30% less, give or take. Now, again, that means if my first set price was 100, what would be my second set price? About 70. That's how you want to think of it. I don't want to see you value something too low or too high. By the way, if you could tell me what an insurance pays for one code, I can tell you what it pays for the other, because every code has a relative value. By example, do you know an exam 99203 is worth 3 times the value of your acupuncture code? And I bet many of you undervalue that. So that means the price of a 99203 based on relative value and cost should be 3 times that price. Where this helps you, though, is you want to start to think of, what about the states like I mentioned, like Texas, that they look at your RVUs and give you a set fixated number to multiply, 6483. By the way, Medicare takes this and goes by about $33. Now that varies a little bit depending on your location and state, but on average. So what I hope you can take from this is, when it comes to your fees, when you're updating this year, think of the fee differences. Your difference between each code, you'll notice it's about 25% when it comes to the electroacupuncture, but you should be in the 25 to 30% range between the codes. By example, if I bill $100 for a service, but an insurance is willing to pay $120, if I bill $100, how much are they going to pay me? $100. But they would have paid me $120. Have you ever noticed no one says, oh, by the way, we would pay you more? So you really want to start to do a fee survey. That's one of the things I do with our offices. If you do our seminar, or of course our network, I really dig into that and start looking at what's your area. What are the costs? How do we look at the relative values? What do other fee schedules tell us? Because you have to start thinking, when you're setting a fee, what is usual and customary for your area? What is it the average? But also, what is fair? You got to think of, I might have an area where I could charge more, but you might say, no, Sam, I want to value it because I want to take care of the underserved group and have my practice more based on cash patients, which are perfectly fine. But then we know that, and that could be why your fees are a little bit lower than the average. Because keep in mind, it says here, may I have a dual fee schedule? Not really. You have a service and a fee. Now, I will clarify, can you have a fee schedule that is for your contracted groups like ASH, $26, $40, sure. And then your regular insurance price, because it's by contract, technically, yes. But once you've set a fee for insurance outside the contract, it's pretty much the same across the board. You're not going to have $100 for insurance and $50 for cash for the same service. Way too far off. Remember, you do have to collect, meaning if you're billing 100 and you're not contracted, you're collecting 100. If the insurance pays some portion of it, great, the patient pays out of pocket. So start to think of, for fees, what's fair? What would I pay? And what do I expect my patients to pay? The value of my service. Remember, create value, people will purchase. Remember, the cheapest office is not always the most successful. In fact, often not, because it's perceived it's not as good a value. give the patients good care, a fair and reasonable price, but being cheaper isn't always the thing. So I'd like you to start thinking of, if I'm going to raise my rates this year, how and where do I do that? Do I use relative values? Do I look at common fees in the area? Yes, you should do all of that. I would look at your work comp fees. The simple rule might be just looking at the Medicare fee schedule and thinking what percentage above that, because at least that way you're doing relative values. It's one of the things we give at our seminars is you get your fee schedule for Medicare and then can start to work off of that, or even better, we work one-on-one on that. Because you got to start to think, if it's first of the year, it's time to start thinking of that. How do I raise my fees? Do I have to inform everyone? You just raise your rates. You're certainly going to put notice that you've increased, but simply you're just increasing. Be careful. If you're not increasing, no one will. What if you're billing below what they allow? You're simply going to get that allowance. Don't be afraid to do more. And what if you're a network? Have you ever thought about asking for a raise? What things do you need to do to get that raise? You know what you have to do? Really create a value to them. Show, hey, I've been in your program for many years. Here's the cost of my services. Here's the value I bring. I'm a tier 6 doctor, let's say. You're also an underserved area. The more you can. I will say I've had a few offices this year. When I say this year, I should say 23, that actually have gotten a 50% increase in their rates from managed care, particularly ASH. It's something I'm finding is happening more if individuals are requesting it and you're in good standing. What I want you to think of, though, is that it's first of the year. Have cost of living gone up for you generically? How has that gone up in your business? Have you really started to set a precedence? If you don't raise for years and then raise it 10 or 15%, people go, oh, wow. But what if you raise just a small percentage every year? Keeping yourself within range and keeping in mind how to balance whether you want more cash or more insurance. But what I'm careful of is if you're not mindful of your fees in your store, no one else will be. I'm going to say patients at the end of the day are going to be the ones that are going to dictate, what can I charge? What insurance is allowing? That's not going to be the end all be all, but it gives me a feeling for it. What about my contracts? How do I make those work? That's what we do with the network. It's what we do with our seminars. This just is a thumbnail. Start to learn how to really make your practice do better. And it's not just about insurance. It's about everything and being successful and enjoying what you do. The American Acupuncture Council is your partner. We want you to be successful because if you're not, you have no need for our services. We are partners. Good luck and best wishes for the year.